Here we have a patient, 50-year-old male, who came with acute breathlessness to emergency room. He is a known case of coronary artery disease, high blood pressure, cholesterol, diabetes. But last 1 hour he is having acute breathlessness. He has come to emergency room now.
Yes, sir. So first we will go to initial 10-second assessment, sir. First we will look whether the patient is conscious oriented.
He is fully conscious oriented. GCS is full.
Okay. So how is the airway, sir?
Airway is good. He is able to breathe, but he is having tachypnea. Heart breath rate is around 35.
Okay.
Difficulty in breathing is there.
Is there any pooling of secretions or gurgling sounds, sir?
It's there.
It's there.
Mild pooling of secretion is there. Froths are coming from the oral cavity.
Okay, sir. So breathing, sir, you already told he is tachypnic, sir. So how is the chest movements and all?
Chest movements are good. Both sides it is good.
How is the respiratory rate, sir?
Rate is 35.
Saturation?
Saturation is 90.
Okay, sir. Then I would like to examine his chest for bilateral air entry or any added sounds.
Make the patient sit.
Yes, sir.
Please make the patient sit.
Please prop up the patient.
Propped up position. Okay.
I would like to auscultate on both sides and posteriorly also.
Okay. Posterior also we can auscultate.
And the cardiovascular examination also.
But you forgot to start oxygen.
Yes, sir.
That's a wrong this one. So whenever patient come with a very low saturation, before auscultating we should start oxygen.
Yes, sir.
Can we start now?
Yes, sir. Start on oxygen.
Please.
Start on a NRBM preferably or a face mask.
Okay. So we have started oxygen.
Propped up the patient.
Okay. You examine the patient's chest.
Yes, sir. What is the finding, sir?
Bilateral crepitations are there, coarse crepitations are there.
Okay, sir. So mostly he will be in cardiac failure. Okay. So initially we will start on oxygen, but he might require a positive pressure ventilation. So by that time we should arrange for a BiPAP.
Okay.
Okay. As a bridging therapy, we will go ahead with oxygen.
You want any additional information?
Yes, sir. Sir, is he having any fever or associated?
He is not having fever.
Is there any past history of COPD or something, sir?
He is a smoker.
Yes, sir. Okay. Is there any wheeze or any other added sounds other than crepitation?
Only crepitations are there. Wheeze, mild wheeze is there, but crepitations are predominantly all over the lung field. It is there.
Okay. Sir, how is his heart rate?
Heart rate is 120.
Okay. Blood pressure?
Blood pressure is 140 by 100.
Okay, sir. Is he having any raised JVP? Or
JVP is raised.
Raised. Okay. Then I would like to examine for any pedal edema also.
Pedal edema is present.
Okay, sir. So mostly he looks in cardiac failure, sir.
Okay.
Disability is a sensorium full, sir?
GCS is full.
Okay. Okay, sir. So he looks in cardiac failure.
Yes.
So we have propped up the patient, started him on oxygen, arranged BiPAP. So we will be starting positive pressure ventilation soon.
You want to reassess the patient?
Yes, sir. After starting oxygen, how is the saturation?
Saturation has not improved. It's slightly improved. From 90, it has become 92.
Okay. How is his chest exertions? Is it the same or?
It's same.
Same.
He is having that same difficulty even with oxygen.
Okay, sir. So mostly he will be better only with the positive pressure ventilation, sir.
Can we start?
Yes, sir. If at all he is having oral secretions, we will have to do suctioning also.
Okay, please. You want to do suction first or?
First we will do the suction first, then we will start on bite.
Do suction. Suction done. Suction done.
Okay.
Now you want to keep him on BiPAP?
BiPAP. Simultaneously, if we have another staff, we will ask them to place 2 large bore IV cannula.
We'll put a large bore IV cannula and you can start the BiPAP. What rate? What depth?
So a BiPAP setting we can keep pressure, inspiratory pressure of 12 and a higher PEEP so that patient will be feeling better. Sir.
Okay, so we have started BiPAP.
12:8 we can start.
Okay,
sir.
saturation has improved.
Okay, we will be targeting a saturation of around more than 94%. If at all he is not achieving that with BiPAP, with oxygen we will BiPAP with oxygen we will be starting.
No, it is 95. After 15 minutes of BiPAP, it is 95.
95. Okay, sir.
Anything else you want to reassess?
Anyway, he is in cardiac failure. His respiratory rate, how is it, sir?
Rate is 30 now.
Okay.
35 it was, slightly reduced.
Saturation already
Saturation improved 95.
95. Okay. Then we will have to, mostly it is cardiac failure, so we will be doing the other adjuncts, like we will be starting in one. Already we have placed 2 large bore IV cannons. We can give some medications for him, sir.
We can start.
Okay. We will give furosemide. Furosemide 40 milligram can be given.
Can you give furosemide 40 milligram IV?
Stat will be given.
Stat. Given? Okay.
Followed by we can start him on Lasix infusion. We can start him on 4 mg per hour infusion can be given.
You have to start Lasix 4 mg per hour infusion after bolus dose. Can you start?
Yes, sir.
Okay.
Simultaneously, if we have other staffs, we should catheterize him, and so that the cardiac overload will be whatever Lasix we are giving will come out as urine output.
Catheterized?
Patient
Okay. Patient is catheterized.
Then we should ask for chest X-ray.
Chest X-ray shows bilateral diffused infiltrates.
Okay, sir. So mostly it will be cardiac failure induced features only. Then if we have a ultrasound machine, we should confirm our findings with the ultrasound machine. With the probes, we should check for the BE lines, and we should rule out any effusion or anything as there.
BE lines are present.
Sir. So it is mostly cardiac failure only. And we should reassess his blood pressure. Sometimes patients, if we are starting on BiPAP, there can be hypotension also.
Now the BP is 140/100.
Okay, sir.
Even after BiPAP, it is 140/100.
So to improve his cardiac status, we can start a low dose of NTG infusion can be started.
How much you want to start?
Since the BP is 140/80, we don't want to reduce the BP much, so we can start in 5 microgram per minute infusion.
Can you start 5 microgram per minute NTG?
NTG infusion
Started.
So this time we should monitor the BP whether he is going to hypotension or not, because his BP is in the correct range itself. If it all BP is high, we can increase the NTG infusion. So we should adequately check the BP every 15 minutes since he is on NTG infusion. Basically, through NTG infusion, we want the coronary vasodilatation and his symptoms will be improved.
Okay. Any other adjunct you want to investigations you want to do?
We will be looking the CBC, NT-pro, BNP and cardiac enzymes.
BNP is very high.
Yes, BNP is high. So it is cardiac failure features only.
Okay. How do you want to proceed? You want to give any consultation?
Yes, sir. We should give ideally a cardiology consultation for this patient. He is in cardiac failure, and he should be shifted to the cardiac care unit, sir.
Okay. Thank you.